speaking about flow cytometry and beyond. And as you know, flow cytometry was first invented in 1953 by Max Foley and patented by Butter Group. And he will be speaking about this technique. We heard about 3DC. Now we'll hear from him about flow cytometry, in which is going to be the first one of the two. So I welcome Dr. Anil. Please go ahead with your presentation.
Yeah, that's good now. Okay. So just around noon, so good noon to everyone. And I think I'm at the best point at the moment because all of you had a cup of coffee, you guys are awake, I'm assuming, and we will see that in between the talk whether we are really awake or not. And thanks to the organizers for inviting me yet again for the same talk, which is flow cytometric cross match. You know, as Ankit was telling me, I can now remember my slides even in my dreams. Okay, so this is the place where I work. This is a hospital in Delhi at Pusa Road. Thankfully, we're not inundated yet in the floods. And just because of the floods, I had a delayed flight yesterday. But this is what I have done with my talk today. I'll give you a brief introduction of what flow cytometry is all about. We'll have some quiz time just to see whether we are all awake. Some essays with respect to flow cytometry in general. And we'll talk about flow cytometric cross-match in particular, slightly more in detail. And then see as to how time permits us and take summary and take home messages. Alright, so what is flow cytometry? How many of you have seen a flow cytometer by raise of hands? Okay, so we do have a few members here who have seen. So flow cytometry is nothing but the measurement of cells when they are flowing in a stream. And all this happens in an instrument where we allow the cells to follow a particular path and we interrogate them at various time intervals and figure out what we are dealing with. In a typical flow cytometer, we have three components of fluidics, optics and electronics, and I'm not getting into details of that. But just to suffice that we need to get cells in suspension, they have to move through the optics wherein the laser will fall upon them, and then finally the electronic signal, which will come as an analog signal, converted into a digital signal in the form of a graph or a plot on the computer, which you will see. Now this is a classical example of how a flow cytometry system is inside of a machine. And if you notice, you have what is called a flow cell. You have these cells which pass through the flow cell in an area where the laser will fall onto it. And once the laser falls onto it, we will be able to get what is called the size in terms of what is called forward scatter. And all the light which falls on the 90 degrees, which is called the side scatter, is made to go through various mirrors and lenses into what is called photo multiplier tubes. These are devices which pick up the light from the instrument, and then they converted the thing into an analog from analog signal to a digital signal. So this is a laser beam hitting the cell. As I told you previously, forward scatter gives you the size, side scatter gives you the complexity, and in addition to that, if you look at the cell, we have these antigens, and that's what we are interested in, right, as an immunologist. So what do we do? How do we identify them? We use these fluorochrome tagged antibodies, all these stars which you're seeing over here. They are nothing but fluorochromes which are tagged to the antibodies, and when the laser light will fall onto them, they will obviously get excited. So they get excited, move to the higher orbit, and when they move to the higher orbit, we know that higher orbit cannot remain for a long time. We all have to come down, even if we are in the high spirits, and this thing will get released as a newer wavelength which will be picked up by the rest of the photomultiplier tubes, and once you get that data, you are converting into a digital signal or a data plot. So what you would notice in this case is you're able to identify all the antigens on the surface by use of monoclonal antibodies tagged to a fluorochrome using a laser light. Now when you look at a cell, the cell has got a cell membrane. You can identify the cells on the membrane, the antigens on the membrane, which is what most of us do most of the time. You can also get into the cytoplasm by permeabilizing it and looking at the antigens within that. You can look at it, the nuclear membrane. Even you can pick up the DNA material, etc. on a flow cytometer. So practically when you look at a cell, anything and everything in the cell can be identified using flow cytometry. In addition to all that, when we do CDC cross match, what do? We add a viability dye, a dye which is picked up by the cells when they are dead. Here also you can do the same experiment on a flow cytometer, By using a dye, for example, lithium bromide or propydiodium iodide or 7-AD, all these dyes can be picked up, and you can actually pick up your dead cells separately. So can we do a dead cell kind of an assay on a flow cytometer using a CDC, like just the way you do a CDC cross match? Yes, we can do that, and I'll show you subsequently in some of my slides. So this is what happens. You get the display plots, and on the display plots you get this data. All these are dot plots which you're seeing in front of you, and this one is what is called the histogram here on the lower left corner. And then these are called density plots, density and contour plots, and on top of them, as a software activity, you create these margins or gates around them. This is what is called gating, so as to analyze that particular cell population alone, and subsequently you subgate and identify what you are dealing with. Now when you come to a classical flow cytometric cross match, this is what you do. You take the lymphocytes by using what is called a phi-col hypake. You get them into a mononuclear cell suspension, just as the way you're trying to do it for CDC cross match. And those cells, you label them with a T cell marker and a B cell marker, and you differentiate them on the scatter plots directly, and then on them you identify whether there is an expression of IgG or an IgM if you're doing IgM cross match on flow as well. So now flow cytometry in transplant immunology is basically not an antigen detection or an antibody screen. It's actually a detection of an antigen antibody reaction, and that's a classical thing for any cross match for that matter. Now you also have something which people keep talking about and thinking, they're always envious. What they would say is neighbors envy and owner's pride. In Onida ads, you remember when I was a kid, and they would say, oh my god, Luminex, I have a Luminex, I have a Luminex, and the other guy would keep feeling very bad, oh I don't have a Luminex, what will I do about it? But for God's sake, Luminex is nothing but a single application flow cytometer. It's also a flow cytometer, and if you look at it properly, what you will notice is this is nothing but a flow cytometry platform as well. Now if I explain it to you in my subsequent slide, this is how a Luminex platform is. You again have a laser light. The only thing is that there are two laser lights. You have a flow cell, and in the flow cell the cells go the same way, or the beads go the same way, and then you have this photomultiplier tube which picks up only one of the fluorescences. So when I say Luminex is nothing but a single application flow cytometer, I am not exaggerating and I am not lying. So if I compare both of them, this is how a conventional flow cytometer is on the left hand side of the screen, and this is what you have is a Luminex platform. So practically a Luminex platform and the flow cytometer are similar principally. So what am I trying to say? If you don't have a Luminex, don't worry, don't be so envious, don't be jealous, don't worry about it at all. If you have a flow cytometer in your system, because many of the hematology centers will have it, you can use flow cytometry for doing what you want to do in transplant immunology exactly the same way, and I'll show you that in my subsequent slides. Now when you look at flow cytometry principle, just as any other cross match principle, we start with this. What do we start with? We start with donor cells and we start with recipient serum. As simple as that. And we also, what we are trying to figure out is presence of an anti-lymphocyte antibody which is present within the recipient serum. And how do we identify it? We identify it in a flow cytometer by taking another antibody which will be against this particular antibody and is tagged to a fluorochrome. Pretty simple, isn't it? So this is what we do on a flow cytometer. We have these lymphocytes, and the moment we say lymphocytes, we call it cell-based. The moment we add identifying markers to identify T and B cells, CD3 for T cells and CD19 for B cells, they are again fluorochrome tagged. You're identifying T and B cells separately, and on top of it, when you're adding the serum of the patient, the antibody which was present in the serum, pre-existing one, goes and binds to the antigens present on the lymphocytes, and then to identify this antibody, you've added your fluorescent and tagged antibody on top of it, which gets fluoresced by posting laser onto it, and you get the information out. I hope we have all understood. It's pretty simple, isn't it? So that's what happens in a classical flow cytometry case, and as you would notice, this is an IgG platform that is done in this case. And mind you, remember, cell-based. The top left corner, cell-based, because we use lymphocytes. Now let's say I replace the whole thing, I move the cells and I use beads. The moment I use beads, there is no cell there, and the moment there is no cell here, the rest of it still remains the same. I'm using a class 1 or a class 2 HLA bead, and I'm putting that in the flow cytometer, and this is nothing but a solid, which is bead based assay, right? So I can do it on a flow cytometer just as the way I did a cell based assay, and we do the same way. It is already coated with the antigens. If there is an antibody in the serum, it will go and bind to the bead, and then I'll use this red antibody on top of it, which will go bind there, fluoresce, give me the reaction, and there will be a medium channel shift, and that will give me what is called a bead based or a solid phase assay. And I can do it on a flow cytometer just as the way I do it on a Luminex. So if I look at assessment of pre-assessment of antibodies in any case, we know that we have cell-based assays and solid phase assays. And if we go internationally through various nephrology forums, guidelines, etc., it is generally said that you should do at least one cell-based assay and one solid phase assay before you go ahead with a transplant, right? Now I will modify this picture, and I have actually modified this picture a little bit, and I'm just trying to say, just concentrate on this area. Flow cytometry, which was previously thought that it's only cell-based, it's actually an overlap between a cell-based assay and a solid phase assay, and you can do both either on a Luminex or on a conventional flow cytometer. Now, how are you able to do it? You are able to do it because you're marrying the solid phase assay with flow cytometry, the conventional flow cytometry, and in that you're using these beads. The beads have nothing but a gradient of color in them, so you're able to identify beads separately, and the color in the bead actually determines where they will fall in the scatter plot. So you're able to identify them separately at different time points, and I'll show you that in my subsequent slides. You can also attach on the beads any protein that you want to identify. So if you want to identify HLA proteins, we'll attach HLA proteins. If you want to identify oligonucleotides, you identify oligonucleotides, or whichever other antigen you want to identify. For example, people talk about C1q, C4d, etc., etc., etc. All that can be done on this instrument. And what is a classical bead? This is how a classical bead is manufactured or defined. It's got a core. The core is a polystyrene core, and this is what is used in Luminex, and I'm sure Dr. Shruti ma'am will talk about it a little more. And then we have all the other layers on top of it. Why am I wanting to show this is because the difference between the bead and the cell is bead will always remain constant in its size, shape, fluorescence, etc., etc. Whereas cells will depend. My cell will fluoresce slightly differently than the others, and that's why there will be a little bit of variability in cell-based assay versus a bead-based assay. And when you take beads, depending upon what you have done on through the beads, you are able to define your assay. So for example, if you have a bead with HLA proteins, you will be able to identify anti-HLA antibodies. If you use a bead in which you have multiple HLA antigens, then you will use it for a screening. If you have a single antigen on the bead, then you will do it as a single bead assay. And if you are adding complement to it, you can do a complement-based assay. So practically speaking, when you look at the Luminex assay, or a flow cytometry based assay, a solid phase or a cellular assay, the solid phase assay is completely dependent upon the bead that you use. So it can be used on a conventional flow cytometry platform as well. Now these are the various beads which you have, flow versus the Luminex. On a flow you use what is called microparticle beads, which are slightly different what is used on the Luminex assay. But for all practical purposes, I want you to concentrate on these things which I just highlighted. They're not standardized. Their antigen integrity is variable, and the antigen orientation is also unknown. Okay, so when you do assays, you develop assays. The assays are developed for naive antigens. For specificity and sensitivity, you will have to relook at it in your own centers, and then only you will be able to figure out whether the assay is good, bad, or ugly. Now I have given you the prelude, the prefix about the entire concept of flow cytometry and Luminex flow cytometry, if I may call it so. But the first analysis of flow cytometry happened by this man. I know a lot of us know Paul and Terasaki. How many of you are aware of this fellow's name? A show of hands. Even I was not aware before preparing my presentation about 7 months back. Okay, so this man is Gorovi. This is the guy who actually did the assay for the first time in the world and published it. And that has been a game changer as far as the flow cytometric cross match is concerned. And I know all of you get 0 in this, but never mind, we have other questions coming in. We are in Tollywood area, Telugu area, am I right? Yes. And Tollywood has contributed significantly to transplants. Do you know how?
It's a recipe.
Okay, fine, that might be one part of it, but I am talking about the Tollywood, how Tollywood gave us this particular amazing thing which happened in the world. which has never been replicated ever again. And can you at least guess the name of the movie? Hriday? Kalyan. Fantastic, yeah? You guys are super. So now we know why this place has given us so much of transplant immunology, thoughts. But if only this is how it would happen, life would be simple. I wouldn't be talking on this platform. I think probably the hero of this movie, or maybe Steven, somebody who is the director, would have been speaking here on the stage. Nevertheless, this is how Tollywood gave us the concept of transplant. And how would Bollywood be far behind? Do you know what's happening here? This I've taken from a video from the YouTube. You see a plate here? There is brain inside. And this thing behind, what is this? This is an oven. And this is the woman, this is a dead man whose brain has been taken out, kept in the oven for some time, till they got this body and they transplanted the brain in. Yeah, and heat inactivated, no issues with respect to bacteria, fungus, virus, etc. And then fantastic, she wakes up and she becomes Mithun Chakravarti in a woman's body. God, if only this is how it would be, life would be very simple. And the movie's name is Diya or Tufan, assuming that most of us would not know the name, I have given the name above. Alright, so when we look at various transplant scenarios that we have across when we're doing transplantation, we do lots of tests. We saw how Madam gave us about CDC, the old is gold part of it, the T cell and the B cell cross match, and the extended cross match, and the AHG cross match, and the DTT cross match, and the flow cross match, and the pronase cross match. We talk about endothelial cross match, we were just discussing. Of course, auto cross match we all need to do, and then virtual cross match. Now, these are the various goals which are there. Why I'm wanting to do this is patient safety and graft longevity. That's what our primary aim is, and that's when I say when we do HLA typing, high resolution, we're not looking at relation, whether I'm a brother or a sister or a mother or a father or a cousin. We are looking at compatibility in terms of immunological, attachment between the two. And will I be able to accept that organ eventually, and how much of a risk do I have subsequently, and what kind of algorithm should I follow for the post-transplant treatment of this patient? Nevertheless, that's the concept, and therefore concentrating specifically on kidney, we are concerned about the donor-specific antibody here. And this donor-specific antibody, of course, we all know we're not wanting a hyperacute rejection, and I'll not get into pathology of this. In addition to that, post-transplant, you're also concerned about the fact of de novo antibodies which will come up where you want to interfere. So in all of these cases, you're wanting to assess an antibody sensitively, pick it up quickly, so that you're able to do something about it. Otherwise, it's always nice, you can put a head into the sand like an ostrich and think all is well. So that's where old is gold works, and that's where the new thing which is coming up in terms of flow works differently. And this is what has been shown, and I know all of you know these cervical survival statistics much better than me, these Kaplan-Meier curves, where a pre-existing antibody or even a de novo antibody has resulted in a poorer graft outcomes. So what are the various tests? We all are aware of so many other tests, but what are our expectations from a test? What are your expectations? When you get a test done, you're always expecting, you want to identify the donor-specific antibody, you want to quantify the donor-specific antibody, you want to correlate and make sure that it tells you predictively very nicely that this guy will have a hyperacute, this will have a chronic ABMR, etc., etc. And then you also want it to correlate with effectiveness of desensitization and rescue therapy. This is what your targets are. But sorry, this does not happen with all of these tests. If you look at the test, pre-transplant or a post-transplant setting, you're basically trying to do a compatibility, and in that there will be a lot of ifs and buts which will come up. So I'll just show you two quick cases. A 32-year-old female, otherwise an end-stage renal disease on hemodialysis, group was AB positive, no recent transfusions or immunosuppressants, and the donor was a 55-year-old male. Flow cytometric cross-match was positive for T and P cells. All the other tests were negative, and the match was only 1/6, low resolution HLA typing. This is a previous case which I'm sharing with you. Now, other tests which were done on this case, those days we used to do Luminex lysate-based cross-match, was negative for T and B, as well as PRA class 1 was positive, class 2 was negative. Class 1 was 33%, class 2 was 0. And there was what is called non-representation of alleles on the SAB assay. So even though you did a SAB, the SAB was not helpful to you because SAB did not have the representation of those antigens. The other case, and the flow, so flow picked it up, whereas SAB actually missed it. So you would have said, oh, flow is now a false positive. But the fact is, flow actually was giving you the information up front. The other case, almost similar profile, except that in this case the flow was negative, the SAB was negative, everything seemed hunky-dory, you could have just gone ahead with the transplant. But a CDC cross-match with the second donor was positive at 37 degrees centigrade. Flow and SAB negative in both the cases, and when you did a virtual cross-match, you found that there was a positive cross-match in this case. Of course, we had to tread with caution. What am I trying to say here is the flow cross-match here was negative. So did I say that flow was very good on one side and I said flow on the other side was, kind of not doing it very well? Yes, the fact was that flow was negative, and in this case we put it up in dilution. 1 in 4, 1 in 16 and 1 in 32, and there is something called a prozone which Dr. Rajeshwari actually explained very beautifully, and you have a low titer antibody, a high titer antibody, and when you actually post dilution your titer becomes exactly equivalent to the antigen density and you're able to get a positive reaction. So practically any antibody detection method is good as long as you know what are the fallacies associated with the associated test. So coming to the detection methodologies, you have cell-based and the solid phase, and as Madam has also shown in her talk, there is a sensitivity pattern which needs to be kept in mind. You have a cross-match which is Luminex, which is high on sensitivity but relatively low on specificity unless you do a specific cross-match. So let's look at the issues which are usually associated with antibody identification in different assays. You can have cell versus solid, and I am concentrating primarily on flow. You can either take cells or you can take single antigens. There are limitations, of course, lots and lots of missing antigens, cross-reactivity, and I'll not get into details of this. But remember, you also have confounding variables like sticky sera, interfering factors, autoantibodies, etc. And most importantly, which you all are concerned about, clinical relevance. Is it really relevant in terms of relationship to a cross-match, and does it really affect the graft survival? And of course, we have enough studies on that so far. But I will actually put it across to you in one simple article which has come across quite some time ago in 2014, and that says nothing is perfect in the art of defining HLA-specific antibodies. So even on one side, when I'm saying that flow is fantastic, it gives you a much higher sensitivity, I'm not trying to obviate flow of the fallacies which it might have associated with it. So what is the purpose of a cross-match? The purpose of cross-match is not only to try and make you select the best possible donor in a circumstance where you have many donors, but even with the donor that you've already selected and you don't have a choice, you should already know upfront what is your possibility of having an event. That could be any event for that matter. So imagine we are only talking about only the risk part of it. We're not saying it's contraindicated or you cannot do it. We're only telling you there is a presence of an antibody. And of course, we're also talking about which antibody against what and how difficult it is to treat. I'll not get into details of that. So when we do flow today, the idea of doing flow is to counter the low sensitivity that you have with CDC cross-match despite doing, say, an extended one or an EHG. And we already know that it's relatively more objective rather than being subjective. So we are having a median channel shift which we work on, or a ratio, and with that we're able to give you a much better and a quicker response. I'll not get into details of these, the procedure per se, but I'll just show you quickly how the whole thing works so that we're all. So it's like the serum and the cells, which I've already shown you previously. From the recipient, it's the serum. From the donor, you take the cells, but you also take the cells from both of them separately as well, just to put up an auto cross match to see how the auto cross matches work out. And once you have taken the cells from the donor, you phi-call it, you get the cells out, and take those donor cells and mix them with the serum of the recipient, okay, after centrifugation. And this serum and cells, you mix them as quickly as you can, and then this is something which I already showed you, right? So you have a possibility of picking up your T cells with the use of CD3 and identifying the presence of this anti-IgG antibody, because you have used an anti-IgG antibody with a fluorochrome to identify this blue antibody here. Similarly, using the CD19, you identify your B cells, and then on the same premise, you're taking this blue antibody, trying to pick it out by using an anti-IgG antibody, which is fluorochrome tagged. Now, when you extend the same thing by doing an IgM cross-match, all you have to do is replace the anti-IgG by an anti-IgM. That's what you're trying to do here. And in this anti-IgM antibody, it's able to identify the same thing, but an IgM1, the classical IgM1. So this is the one which is generally suggested as a pool, as a tube numbers that people use when they are setting up only IgG. And what we do in our center is we not only do the IgG, we also do the IgM. So we have a 9-tube assay. A lot of people use 9-tube assay globally. In addition to that, in an IgG, we also use a dilution upfront of 1:2 and 1:4. And if we get a rising trend in that, we may add 1:8 and 1:12 as well. Of course, that makes the assay a little more expensive, but it makes relatively life safer for the patient. Of course, we also need to remember one very clear thing, that we need to have a calibrated instrument, very well calibrated instrument that too, and the protocol should be set up nicely. There is a concept of median channel shift which you should keep in mind. That's a shift from a negative versus a positive, and I'll show you that in my subsequent slides. And you look at the cases versus the control in terms of the median channel shift. Either you use a scale which is a log scale on 256 or a linear scale in 1024, and you ultimately can represent it in the form of ratio. Most of the people today are happy putting it up as a ratio. Less and less people have started using the scales directly. And this is what the assay interpretation is. Practically, if I tell you, it's not a very specific assay, in the sense it cannot tell you whether you're dealing with an HLA antibody or a non-HLA antibody. It cannot even specify specifically whether you're dealing with class 1 or class 2, but more or less, if you have found a flow cross-match positive, it is an indication for you go to the next higher testing for sure. So this is how the whole thing comes up. You have the gated lymphocytes. These are your lymphocytes which you picked up. You identified them as B and T. And then in a negative control, this is where the graphs would be, right? And when the graph would move rightwards, just as the way it's moving rightwards here, that shift against the negative control is what is called the median channel shift, right? And that is quantified in terms of the data which is coming out from a flow cytometer. Now, why do we use median? If you see, the graph is not a typical, a typical curve where we can take a mean. We can't. So in this kind of a graph, which is so haphazard and drawn out, we take median, and that's the best way to differentiate between the two. That's why median channel shift is what is preferred by most of the people now against a mean channel shift. Just to show you a case from our center, this is a mononuclear cell gate which has identified lymphocytes. We've converted into T and B cells here. The B cells, the T cell is showing a reaction which is on the first log, and the B cell is also showing the first log. This was a negative control, and obviously we are expecting everything towards the left. Now just look at the next one. In the next one, see what has happened to these peaks. They have all moved towards right. So that tells you there is a significant median channel shift, and this is a classical positive control. So you've seen a negative control, a positive control. And then when we look at IgM, this is how IgM looks like. Just look at the B cell IgM, it spreads out. The reason is because B cell has got a higher number of Fc receptors, and the IgM, is a very sticky antibody. It goes and binds to that a little more, and therefore you're able to get that kind of a shift in your graphs. So therefore, it is numbers which become very important when you look at flow cytometry. And here, this is a positive case. Just see this T cell, it's moved rightwards, but in B cell, from what you had seen in the previous slide, it will be difficult to differentiate how much of a positivity did you get it on the graphic pattern. But when you look at the numbers, you're able to actually decipher it very clearly. This is some data from our center. We started very slow in 2013, and of course before that I was working in some other places. And this data shows you a significant number of rise in flow cytometric cross-match cases. And if you look at the cases with respect to positives and negatives, you had a significant number of positive cases, about 17% which were IgM picked from flow cytometry. And this data I have collated just yesterday. Now coming to solid phase flow cytometry, and I'll quickly take next maybe 5-10 minutes to show you, we are actually doing what is called a panel reactive antibody assay. And again, the purpose is the same as I told you previously. I'll not get into details of that, but just remember, a bead-based assay for PRA on flow cytometry using IgG can either be a screening assay or a specific assay. And all you use in this case, as I told you, is the beads which I showed you in my first few slides. And those beads, because they're colored, they're identified differently on a flow cytometer scatter plot. You can see you have this plot, this bead here, and the bead is separated from each other. And then you gate those beads. So this is a screening assay where we have used. This is a negative control. You can see all the shifts are towards the left-hand side. And as we move to the positive control, the entire thing gets shifted to the right. And in a typical case of screening PRA, just see the negative control and compare what is happening to these assays. They're moving towards the right-hand side and telling you that a screening is positive. Now when you go to a specific assay, in a specific assay, you identify, as I told you again, the beads at various levels because they are colored differently and their concentration of color is different. So flow cytometer identifies it differently. And you put these boxes around it, and these are what is called gates. I told you that earlier as well. Now this is a classical negative control which you've seen. See what happens in a positive control. They've all moved out of the one except one, which is supposed to be all the time negative. It doesn't react at all. This bead is non-reactive. So if you look at these, they have all moved towards the right. And when you take a classical patient, you take the beads, you put it with the serum's recipient, and you are able to identify the classical HLA patterns in them. So you can do a microparticle flow based assay, which is a solid phase assay on conventional flow cytometry. What's new in flow cytometry? You have a functional assay, you have a detection of non-HLA antibodies, you can do a therapeutic antibody assay wherein you can remove the effect of rituximab, flow PRA I already showed you, and C4D assay. Cytotoxicity assay, quickly, you're adding the cytotoxicity agent, you're adding a complement to it, and I told you you can do viability assay on a flow cytometer. And this is what happens. You have these cells, the antibody goes and binds to it, you added a complement, the red triangle over here, and then you added a viability dye. The moment cell dies, the viability dye gets into the cell, and that fluoresces differently on a flow cytometer, and you're able to pick it up. And this is various limitations and assay improvements which have happened. We have the presentation with you all here. You can take a copy of this and use it for your thing. So quickly, in a cross match, all these are possible to be done. It uses indirect immunofluorescence. It can detect IgG, IgM both. It eliminates the physical need of separation of the cell, which happens in CDC crossmatch. So old may not be really gold, and can detect non-HLA antibodies as well, just as the way we did it in a CDC crossmatch. The other part of the flow crossmatch, again, remember, it has potential applications in emergency. When you're doing a cadaveric transplant, CDC will take you ages and it will be non-interpretable. And I can actually report this at the comfort of my home, midnight. I wake up, just see the files and report it out. Availability of objective interpretation, I interpret it the same way just as most of the others, if they are trained appropriately. Has a much higher sensitivity and little influence by cell viability, because I can use a viability time. So all this is important and possible. Quick thing about endothelial cell crossmatch can be done on a flow cytometer. Of course, it's a bit exorbitant. A lot of people, I tried doing it, but since the assay cost is too high and not much in demand at the moment, it becomes a bit of a challenge, but we'll see how it pans out. Here again, the same concept. You have these beads which are able to be picked up separately. They identify the endothelial cells, and on those endothelial cells, what's the expression of antibodies. In the monoclonal antibody era, which is the rituximab era and other antibodies that you use, the antibodies go and bind to the cells, and because they're already bound, the IgG is also binding to the same antibody, the drug antibody. Now you don't want that to happen, so you use pronase at a higher concentration. You cleave the bond of the FC and the FAB fragment, so the FC fragment is not there at all, and then when you use this antibody, it will go only to the FAB part of it, and it will identify. So this assay has already been developed very well by most of the people. We have also started doing it in our center. C4D, again, something which was talked about a little earlier, can also be done on capture beads using the beads which are already having a capture antibody that picks up the C4D from the serum of the patient, and then can be done on flow cytometer. And the same thing is actually done by a Luminex also. Now this is one last point which I want to show you. This is a study which we've done in Delhi, and there were 3 centers involved with it, us from BLK, then Apollo and Vedanta, where we looked at, and it was a multi-center, not really blinded, but kind of blinded, wherein we looked at all the 3 tests coming up together, and we saw what is the effectiveness of all of them. Now look at the cell-based assays. Look at the CDC, the so-called gold standard, and mind you, this is an extended CDC that we are talking about, and in this gold standard, your pickup rate was only 12.1% compared to the flow cytometer, which was able to pick it up 100% when we're talking about across centers, across variable groups. And of course, we have lots of reasons. Flow also has its issues, I'm not questioning that. And there were cases where flow cytometry was not able to pick it up. For example, when we are comparing one set of assays on Luminex with flow cytometry, it did give us discrepancies between the two. I'll not get into details again for the shortage of time, but flow cross-match cases are also, negative cross-matches are also known. So how have we come across a classical algorithm and handling it? We have kind of said, leave the old is gold. I think that's enough. Let's keep it dead and buried. It's already kind of taken care of. Let's move to flow cytometry and an HLA and assay on the Luminex platform, which is more like a PRA assay. And if both of them are negative, you don't need to further test at all. This is most likely very, good for us to go ahead. And if either or both are positive, then we go ahead and start doing the rest of the assays, which include your single antigen bead assay, and even requiring the HLA, what is called virtual cross-match. I am only requesting all of you, don't follow me blindly. Just try the same thing in your centers also. Maybe you will come out with something different than what we are already proposing. So to summary and conclude, flow cytometric cross match, IgG, flow, PRA, C4D, etc. They are all assays which are possible to be done on flow. I'm not trying to do away with CDC completely, because CDC at times does give us some valuable information, especially in the circumstances where I have a high antibody volume, because a lot of people don't do flow cross match in dilutions. And of course, it's also been documented very well that flow-based assays, even the solid flow-based assays, are in no way inferior to what you do on a classical Luminex flow cytometer. And mind you, Luminex is nothing but a flow cytometer. And this is what I would like to conclude. The flow cytometry is sufficient to make a final decision in most of the cases, and this is not my center's study. This is a study from the another center in the country, from SGPGI, where it's very clearly showing that it's able to identify most of the stuff very, very well. Finally, nothing is perfect. If you can do all the tests, please do all the tests. But if you can't, at least go and follow an algorithm. And because every case is different, it's a new challenge, and a multimodality approach is the best way to follow. And remember, it's the man behind the machine who's most important. Who is doing your test? Who is seeing it properly? Who is interpreting the test? Does he have adequate training? Does he have the thorough knowledge of the background? All that is equally important for you to realize what you're getting on your plate. This is my lovely team. I give them due acknowledgements for the work that they do behind the scenes for me to come and present the data in front of you. Thank you very much. Any queries, I'll be happy to answer.
Thanks a lot, Dr. Anil. When do you do endothelial antibody tests? Is it routinely you do, or?
No. So in our center, endothelial cross-match is not done as a part of routine. Dr. Shruti apparently is doing it in her center in certain selected cases. We did it as a part of the fact that the vendor came to us with a kit and said that, I have a kit on endothelial cross-match, why don't you just try and do it? So we did it. We did 24 cases. Out of 24 cases, we had 3 positive but weak positive cases. We did not have a follow-up on them, so I really don't have the thing as to how they behaved eventually. But as an assay, endothelial cell cross-match is available. Generally speaking, you may not do endothelial cell cross-match in every case. You may actually do it even maybe post-transplant, and perhaps that's something which probably Dr. Shruti can tell us more about, because I don't have a direct work on this.
Thank you, sir, for an excellent talk. The flow of the talk from basics to the in-depth knowledge has been very good. I have one query. You've told that the bead-based assays also can be done in this flow cytometry. Now, when we elute the HLA antigens to the surface of these beads, do they behave like what are naturally present on the surface of cells, or do they change their form? Because you told that first case where the bead-based SJ has become positive, but the flow cytometry is negative. Could that be?
No. The first case was bead-based was negative and flow was positive.
Flow was positive.
The reason was that the single antigen bead assay, the kits that you get, and I'm sure Dr. Shruti will be talking about it a little more, there is representation of beads on them. It's not that you have thousands and thousands of beads. You have so many HLA antigens. Not all are represented on the beads. So sometimes some of the HLA antigens are not represented, and most of these beads are actually being manufactured in the Europe, and they are directed towards Caucasians. So when you take this assay, you need to relook at what you got as a single antigen assay. Was your HLA type of the donor represented on that particular bead or not, that particular assay or not? And that's very crucial, which most of us don't do. Most of us means the clinical guys. The laboratory people have the obligation to actually put it up on the report that these beads were not represented.
When they are eluted, do they exactly behave on the beads like the same way? Their antigen don't the antigenic profiles change when they are eluted?
They do, of course. So there is something called cryptic antigen exposures. There's something called denaturation of the antigens that also happens when you create a bead. We prepare a bead. Now you don't do it in this case because all this has been done by the company directly. But even if they have done it, you must keep that in mind that yes, there will be denatured antigens which can give you a false positive reaction. You should also remember that sometimes you may not even get, there's no, if you take a naive bead, there is no antigen on it, and you may have a bead itself reacting with the serum of the patient and giving you a false positive reaction. All this has been well documented. A lot of people have published on it from our country as well, including my center, where these things are potentially possible. So that's why I said no test is perfect. So you'll have to interpret all tests in such a way that you're able to get the best possible information for your patients to go ahead with the transplant.
I'm sure there'll be a lot of questions from the audience.
you do IgM flow cross-match?
Yeah, very interesting question and a good question, I must say. So when we started doing IgM cross-match, I was in Vedanta. I was working with Dr. Vijay Kher, and by convention, because we thought we have to pick up antibody. In those days, we were learning, So we thought we just, because we had an IgM available with us, anti-IgM, if I may correct myself, and then we also had IgG any which way. So when we set up the entire assay, we did an IgG and we did an IgM. And I still remember, almost a year later when we reviewed our data, I used to give him so many IgMs positive, almost about 10-12% IgMs positive. And he would, after 1 year, one day we sat across, he said, "Arey Anil ji, kya dete rehte ho ye IgM positive, kya IgM positive?" But little did we realize that these IgMs eventually can have a class switch. We know that. So when we re-looked at the data that we, kind of derived from those cases which we had done in that year, which is 2011 to be precise, we took out the data, we reviewed our data, and we realized that in all the IgMs that we had given positive, out of them, more than 50% had an event of some graft dysfunction. And then when we went back and looked at the data again, we realized 25% of them had a class switch, and at least 3% of them had an MFI, which was pretty high. So that is the time when he also realized, and we also realized, that whatever we started just as a fluke, it worked and it gave us information, and that's why we continue to do it. So whenever we report our IgM positive, our nephrologist, we inform him upfront that my suggestion is wait for 3 weeks, repeat the test. If it's negative, go ahead. If it's not, but keep one thing in mind, that there could still be a striking memory there, and anything that could possibly come up later as well.
So with your solid phase flow cytometers, will you be able to give us an MFI with those microbeads?
Yes. So we will not call it MFI, we will call it median channel shift. That's the only difference between the two.
Will that collaborate?
It will collaborate, because the moment, see again, when you're trying to do it, there's a PRA which is already being done. You give percentage PRA, and that's again based on the positivity of the versus the negative beads that you put in there. So you had a negative bead, you had a shift, and that fluorescence which you're coming on the right hand side, that shift you can measure, and you can actually quantify by what is called milli-equivalents of soluble fluorescence. So that can also be given separately, and there is a proper graphic thing which you can do on that, and you can actually quantify it, real quantification. And you can correlate it with the MFIs which you're getting from SABs, and then once you've gotten a correlated thing, you can actually tell us, I can actually tell you how much quantity is there, and what is the possible thing that, how many plasmapheresis will you need to do it, to get rid of it. All that can be done.
It was a very great talk, sir. So, I'm sure if you talk about the same thing in 2-3 platforms, people will start using solid phase assays on the flow platform.
That's my wish, actually.
Yeah. So my concern was in what situations, what condition do you recommend this solid phase assay and flow platform, and how sensitive and specific it is when compared to the Luminex?
Okay, so there is enough data today to suggest that if I do a Luminex-based assay, and I'm talking about a PRA here, and I'm not talking about single antigen. If you have PRA which you've done on Luminex, and if you've done PRA which you've done on flow, but you've done it correctly, please mind you, correctly. If you've done it correctly, they are comparable 100%.
Is it available in the market, sir? And
yes, it is available.
Cost difference, sir?
So cost-wise, Luminex will be higher. This will be 50% of the cost which you have on the Luminex. And if people start using it more frequently, the cost will probably go down by another 50%. And then it will be equivalent to the gold standard. Gold is gold. Cost-wise.
How many centers in the country are using this?
How many centers are using it? Sir, I am aware of only 2 centers in Delhi. One is mine and one is Vedanta. I have not asked others, but I wish all of you start asking for it. Because when you will ask for it, it's about demand and supply at the end of the day. So if people demand, it will happen. If you don't demand, it will not happen.
Yes.
And more importantly, the demand goes up, the cost goes down. So that's how the whole thing works. And it's the best example is high resolution HLA typing. High resolution HLA typing you would do at a 10 loci at a cost of 50,000 rupees 10 years ago to just 6,000-7,000 rupees today. That has told you what has happened. The bone marrow transplant guys have asked for high resolution typing in every case today. They don't ask for low res anymore. So therefore, the things have changed.
Costs don't often get transmitted to the clinicians.
No, it does. It is.
Yeah, look, I'll not want to get into the corporate debate part of it, but there are enough, laboratories and others otherwise, who are willing to extend the cost benefit to the patient. And there are people who are doing it. The only thing is that you have to find the right set of people helping you out.
How much
Sir,
time
in
it
a
take
center like
for
us,
disease
sir?
donor setting?
So yes, so in a center like us, we don't have the luminance. We want to best utilize whatever flow we have now.
You have a flow cytometer?
Yes, so that's what I just want our people to comment on how we can utilize this our flow for the solid phase
There's
assessment.
no PRA they can.
You have a flow cytometer, you can do it.
For disease
So
donor
if you have a one laser 3-color flow cytometer, you can do it.
So the time taken for the disease donor setting, if you want to do the solid phase,
So if you want to do a solid phase on flow,
yeah, it is for disease donor.
2.5 hours. 2.5 hours,
I
you get the
think-
report.
I think our lab people should
Even
speak.
Luminex is 2 hours.
Luminex is also true.
We get PRA earlier than,
Here I
earlier
think
than the
there's
class.
a, you know,
Luminex, why you save half an hour is because the kit is already available and it is already standardized. In the other one you don't, you have to interpret it correctly. That's where the difference lies.
It's 4 hours.
So that's why I said 2.5 hours you can get it. And trust me sir, when we do a cadaveric in our center, we do a CDC because I know if we don't do CDC, it's blasphemy in our country. But I don't bother about it. I only look at my, flow cross match results, and I tell my nephrologist, take this guy or take this guy or take this guy, based
so
on
you
flow.
want to say that you can just get away with CDC, just flow alone is enough because now you said it acts as
The problem is you guys called it old is gold, so I really don't want to be blasphemous here. But if I have see, I'm not trying to say that CDC is absolutely useless. Please don't take that message from me. CDC has its own advantage in the entire setting. As I told you, in our case also, the second case which I showed you, I had a flow negative. And that is an eye-opener for me because I realized my CDC was positive and I was wondering, why is my CDC positive coming positive then in case my flow is negative. That's when I put up a dilution and I realized in my dilution flow came positive as well. So, because CDC by convention you do in dilution and flow by convention you don't because it will increase your cost. So you don't do it in dilution. So that's
by
why
dilution, how much time extra?
you're doing it at the same time, sir. You're adding just one more tube, that's it.
Like in
3 more
CDC,
tubes.
in CDC takes more time.
CDC is 5.5 to 6 hours, flow is 4.5 hours.
Yeah, less than that
Less
actually.
than that.
So I think it was a great discussion, so I think we'll try to conclude the session because we have other
Yes, thank you
more
very
talks
much.
before lunch to be
Yeah, yeah.
addition
So
of
one-
already 12:40.
Thank you very much.
I have one question. So like CDC and flow will be detecting non-HLA
Yes,
theoretically,
yes.
but practically how much of non-HLA are detected by CDC and flow, because SAB won't be detecting non-HLA. So this doing non-HLA in we had one patient who had rejection non-HLA. We did CDC and flow DS, flow cross match, both came as negative. But theoretically it should have come positive.
So I don't know, maybe that was an antibody which was maybe higher in concentration, I don't know, because again prozone is something which I would want to keep in mind, and I would also not know whether we have done, the extended one on the CDC, and if we would probably have done a dilution in flow, maybe that would have given us a better answer. But all said and done, please remember my one slide which I showed in the start and the end, nothing is perfect. Okay, nothing is perfect. A combination of all your tests is what will determine what you're going to be able to get. And you will still lose out on the cases like what you
Are
got.
all non-HLA will be represented in
Then we can discuss that in our case because we are at case, so we can discuss that in case. We'll pose those questions for that case discussion.
Absolutely.
So